Thank you, everyone. I'm very happy to be here with you, and thank you for the invitation. I hope that you'll find the presentation useful to you and also to your future career path. So welcome. So as introduced, my name is Dr. Kelvin Momanyi. I work for the World Animal Protection as a campaign officer around our food systems work, but also a founder of the Transdisciplinary Consultants. So today's presentation is going to implementation. And these are live examples that I've participated in. I hope you'll find them useful. And if you have any questions, please at the end, be sure to share your questions. So we'll begin by just defining One Health. I know already you know what is One Health, but of emphasis is that this collaborative approach should give us 4 things. One, we have to demonstrate these cost savings of applying the approach, improvement of the health and the welfare of humans, improvement of the health and welfare of the animals, but as well as ecosystem benefits out of the collaboration. So in short, it is not good enough to come together to collaborate. We have to demonstrate that added value of the collaboration. So the case studies, there are 10 case studies I'm going to share with you. So we start off with this case study around medical practitioners in Kenya. So in the year 2016, there was a case of conjoined twins in Kenya. This case was presented to the Kenyatta National Hospital, which is our national referral hospital based in Nairobi, Kenya. So what happened? Different surgeons were brought together, that's the pediatric, neurosurgeons, plastic reconstructive, a project that was implemented in Western Kenya called Zoolink. So Zoolink in full is the zoonosis in livestock and humans in Kenya. One, we had of both medical practitioners and veterinarians. So what we used to do is collect samples, biological samples from the humans, nasal swabs and blood samples, as well as administer a questionnaire screening some health characteristics. Then we did have the animal team, which visited both the livestock markets and the slaughterhouses. And here what the animal team did is that we did a full body check of the animal, looking at the mucous membranes, the lymph nodes, picking of any ectoparasites if they're there, body condition scoring. And then we also picked samples, that is the blood samples, nasal swabs, as well as the fecal samples. So all these samples that were collected both at the health facility for humans and animals were delivered to the field lab that was based in Western Kenya. It was analyzed and results were presented. What we identified is that the project was trying to develop a surveillance system of 15 zoonotic diseases within that particular area. And at the end of it all, we did identify the common zoonotic diseases, and we used this data to share or to sensitize the livestock practitioners as well as the farmers who are both the livestock markets as well as the slaughterhouses and the medical facilities. So at the end, after having our results, we went back to these facilities to share the results with them so that to inform their health interventions. Number 3 is professional association activities. I also know some of you either belong in an association like the IVSA. Maybe eventually you'll want to join your veterinary association or your veterinary board at the end of it all. So activities that are being partaken by professional association, whether it's medical or veterinary or environmental, practical application of One Health. I'll give an example of our association in Kenya called the Kenya Veterinary Association. Some of the activities they have already done is creating awareness around during the World Rabies Day or during the World Animal Day. And by so doing, you're basically sharing critical information with the public on the prevention and control of some of these important zoonotic diseases, like either rabies or anthrax or any other disease that is affecting your area. But remember also during these particular sessions, I understand also as students you've also partaken in some, is you do disease control and prevention outreach programs at the community. The photo on the right shows that you undertake either vaccinations against common livestock diseases like rabies, within your area, foot and mouth disease, clumpy skin disease, and the rest. And by so doing, you're actually controlling and prevention. You're protecting future generations or the community around that area so that they are not affected by this disease. Another number 4 is the FELTEP program. FELTEP is the Field Epidemiology and Laboratory Training Program. I don't know, maybe you might want to ask yourself, do you have such a program in your country? I want to see your comments in the chat if you do, and what do they usually actually do? This is a case example of the FELTEP residents who responded to an outbreak of anthrax in Kenya. So this anthrax outbreak occurred in an area called Nakuru. So at this stage, it's just an activity for us. Assuming that you were the one leading this particular response, you were the one leading the response team of this anthrax outbreak, whom would you bring on board to be in the team that you'll be working? Use the chat to just tell us, maybe take a minute, just write in the chat, whom do you think you'll want to work with as you respond to this outbreak of anthrax in your area, assuming you are the lead team? A local vet, Raul, thank you, I can see that. Let me see more ideas. And absolutely, a local vet will look at the animals. Any other ideas from anyone? Whom do you think you'll bring on board to work in your team? Okay, so let's proceed as you are thinking. I'll give you some responses. Yes, a veterinarian becomes at the top of your list. But remember, during the anthrax outbreak, there could be people who have been affected. I'll go to the previous photo. You'll notice the photo on the left, these are animals showing typical signs of anthrax. Okay, blot, nasal and other dysphagia from orifices, blood which is tarry and black, non-clotting, okay, and rigor mortis. You can see the rhino also, which is affected. The third photo from your left, these are typical skin lesions of anthrax, as well as the photo on the far right. So yes, you'll need a veterinarian, and if people are affected, you'll need physician, a medical officer, public health worker to do that public promotion and to insensitize people about the importance of taking preventative measures. An epidemiologist, so that you can be able to know what is really causing this disease, okay, to know. The wildlife scientists, as you can see, wildlife are also affected. Local leaders will be able to mobilize people. And remember, people do take orders, or they do listen more to their local leadership. Therefore, working with either the local chief or local politician, it can actually facilitate you implementing this, because remember, you might require to gather some funding and emergency funding to respond to this. Communication, a very key thing, because you also want to inform the rest of the people around the area about that impending outbreak and what prevention and control measures they need to take. So this is just a list of possible members of the team whom you can bring on board. Another example is campaigning organizations also do implement One Health. A good example I want to give you is the organization I'm working for called the World Animal Protection in Africa. So World Animal Protection has offices across 15 countries globally, and I know there's an office within India. You might want to look into it and see what we are in the US, North and also the South. We are in Europe. We are also in Australia. Our work currently, I'm going to focus on animals in farming, but we also do have work around animals in the wild or wildlife. So animals in the wild in farming, our main principal goal is to expose that suffering and cruelty of animals within closed doors or factory farms where animals are raised, so many in cramped spaces, and how this is actually connecting to disruption of our environment. The photo on the right actually shows you fields or forests which are being cleared so that to pave way to plant feed for animal use. And this, our research or evidence has shown us that actually this is actually occurring in Brazil and other areas across the world. So we may want to ask ourselves also, is it occurring in India or for feed for livestock consumption? Another thing we do is that we provide solutions. And one of the solutions we do, we have built animal welfare frameworks for both poultry, pigs, and the other species. And you can find them under this FARMS initiative, which is the Farm Animal Responsible Minimum Standards. So these are the minimum standards that we promote amongst the stakeholders, like producers or fast food restaurants, that they can be able to implement them. And the end goal is to ensure that the animals have the best or the good life that they deserve. Why is this important? It's because our evidence as an organization shows us that when animals are well taken care of, their health is high. The health of the public, because of the food safety, is also well taken care of. And also it promotes that sustainable utilization of resources in terms of feed or any other inputs to the animals. But also evidence shows that when you do abuse animals, you tend to use maybe antimicrobials more, especially antibiotics. And by also doing, it results to residues within the meat or the products, which can eventually end up to you taking that meat with residues, therefore exposing you to very small doses of this drug, such that when you'll be sick of a simple pathogen, then you cannot be cured, resulting to that global problem of antibiotic resistance. As you're aware, the World Health Organization has shown that actually by 2030, we'll be having almost 10 million people dying every year because of antibiotic resistance. We also, our work also focuses on working with the financial institutions, development banks, as well as the private financial institutions, so that they can be able to invest in high welfare production systems. This is an example of one of the company called the Standard Chartered Bank. And as you can read that statement below there, they're saying they'll only be providing financial services to agribusiness clients who are cage-free or cage-free. So you might want to ask yourself if such a bank is actually committing to such high welfare practices, then what's the future for our farming? Simply means that our farmers also have to be able to change towards implementing humane and sustainable farming practices. That is avoiding cages, avoiding crates for pigs, okay? Yeah. And lastly is about we work with people, you and I, because we believe the voices of the people drive policy change. They do bring change that we deserve. They do drive solutions within our community. A typical example I can give you is the survey we ran in 2019 in Kenya, Uganda, Tanzania, and Zambia, which shows that actually people can associate poor animal welfare to poor quality products, and they are willing to pay more if they are given products that are actually antibiotic free. These are some good examples of One Health implementation from a campaigning perspective. Another number 6 example is around a One Health project that was implemented in northern Kenya. This project was implemented by 3 partners, that is Amref Health Kenya. It was also implemented by VSF Germany. I know maybe you've heard of them, VSF Germany, and the other implementers like Trim and Dist, who are the private implementers. So the goal of this project was to foster health and resilience of pastoral communities in northern Kenya. So I'm going to take you through step-by-step processes or some examples on how they applied it and whether it was actually a One Health application. You'll tell me that at the end of it all. One, they implemented anthropological approaches or studies to be able to understand perceptions and behaviors of pastoralists towards health seeking, towards maybe why do they consume raw milk, so that the project can be able to develop innovations around to prevent those low practices or poor practices. And as you can see the photo on the right, this is actually an intestine reader. So these local people, they are able to look at the intestine of livestock it's going to rain or a drought is coming soon. So the project also thought it best to work with such local people so that to validate some of these practices, whether they're actually working or not. I don't know if it's very clear. That table below on the right shows that, so the members of the community were asked, what do you think is the level of accuracy in terms of if you use an intestine reader to predict and when you use scientific approaches? You'll notice that actually most community members believe that intestine reader features, they are better in predicting. So using this knowledge, the project thought that they should be able to educate the people. And after educating them, they came to learn that science is more accurate, because if science tells you on a certain date it's going to rain, it's going to be dry, then it becomes very accurate. The project also did capacity building, training of the community disease reporters, community health volunteers, household health agents around zoonotic diseases, around disease prevention, around the importance of women going to clinics, antenatal care. And this shows us that when you build the local capacity of the people, results to that sustainable nature, because these people will still remain in the community. They won't go away. So building capacity within the local setup results to that investment, long-term investment of knowledge within a community. Then these people can be able to share this information to other people, like outreaches. As you can see, they used barazas, going to sessions, religious meetings. Barazas as like a small local groupings where they go to. Sorio, these are celebrations that like the Diwali celebrations, using that to reach out to people to educate them about zoonotic diseases, importance of prevention and control of zoonosis. So what it shows us here, when you are implementing a One Health project, you need to identify focal points or important meetings within your society where you can be able to deliver these messages. Two, importance is that when you're applying a One Health approach, after educating the people, they were able to go to the community and collect data using mobile phones. And by collecting data, it was able to show them the common diseases that are affecting this community. As you can see, brucellosis was one of the top of the list, as well as rabies. So that active disease surveillance can inform planning and decision-making at local level. Other thing is technical assistance. When you're doing an integrated approach of delivering both animal and human health services to pastoralists, what it is showing is that you're actually reducing that morbidity and mortality of animals within the community, because the household agents and the community disease reporters are able to educate the community members on how to prevent and control these diseases, the importance of better hygiene, better biosecurity measures, importance of provision of high quality provision of feed and water to the animals, as well as defaulters go very low. Okay, immunization goes very high. Why do you think immunization goes high? Remember, pastoralists, the distance between where they go to receive health services is usually almost 20 kilometers away. Meaning, if you are delivering these services at their doorsteps, then immunization will go very high and defaulters become very few. This is the example whereby they were delivering these health services through mobile One Health units. So mobile One Health unit in this context, they had animal health practitioners as well as human health practitioners, and they also had some environmental people. They also had some people talking about nutritional and nutritionists within the team. They did almost 192 missions, okay? And what did this do? As you can see, the uptake of OPD services in under 5 and above 5 years increased. People, the pregnant and lactating women, antenatal care also were reached out to. At the bottom right corner, you'll see a statement by one of the local person. He said, or she said actually, it's a she, to the whole community, there are outreaches they do with human health and animal health personnel, that they go far where people cannot access such services. So that's the importance of that integrated approach within this setup of pastoralist community. It delivers the much needed health services at their doorsteps. Other things that the project did is that it developed this, what they call maps, local maps, showing the local communities when it's going to rain, okay? And it used their local languages, okay? And then it also developed a data collection system. So they developed an app called TreeMap. So TreeMap, the data collectors, who are the community disease reporters and the community health volunteers, they'll go to the community, enter the data, then the data is transmitted to a database. Then that database disseminates this data directly to a Telegram group where all these data reporters are there. Some of the leaders from the communities are there, as well as NDMA. NDMA is our National Meteorological Drought Authority, which is also there. So by receiving this data, for instance, if there's an outbreak of diseases, as you can see on the far right bottom corner, it shows mass animals dead after drinking water from a shallow well. When this information is posted within the Telegram group, then there's a response team that picks up that information to go and respond to that particular outbreak. So what it shows is basically that developing, collecting data, pulling it in a database, and in using this information to inform action by the policymakers or some technical people within the community. This one is about, they trained also the students within the local clubs. So there were school One Health clubs. They mobilized them, they trained the teachers, and the teachers were used to train the students. Our interviews with some of these students was actually fascinating. They actually know what is One Health. They know how to apply One Health, like cleaning of the environment, because they know when they clean the environment, then the environment becomes safer, resulting to better health. They're able to associate the importance of boiling milk so as to prevent brucellosis, which, as you noticed, was one of the number one zoonotic diseases within that society. So investment in students results to also behavior change among the adults. Because you'll find that in pastoralists, changing the mindset of a person becomes very difficult. But when you train their young person or their child, then the child goes to pass information to them, then they become more, they listen better to their students or to their kid or child. Another one is they developed information materials. Like this is actually a community health education handbook, which was training the community about zoonotic disease, what's a zoonosis, how to identify, how to control, how to prevent, importance of women going for antenatal care, better hand hygiene, sanitation and hygiene, proper disposal of waste. All this was packaged in a handbook. They used graphic images that are very relevant to this community, because it becomes very easy for these people to visualize and then to see. Actually, they used even images of people resembling people within their community. I believe this is something that as students, even within IVC, you can be able to do this simple, impactful infographics so that you can be able to change behavior, change the community. Then lastly, they are now working to establish a COHU. A COHU is a County One Health Unit. And this is basically supposed to now mobilize funding to implement One Health within their local level. Then here, last one is around, they also give funding to VCOBAs. VCOBAs are these village community bank models. They're basically small women groups across 13 villages. They give them funding. Then what you'll notice is that from the funding, their net worth now is almost 1.2 million shillings. And also their profit on investment is actually very high, almost between 120,000 to 289,000. And importantly is that by investing in women, what we realize also, it created more jobs. Why? The women will go and sit down and say, we want to start a business around selling and buying of livestock, okay? So by selling and buying of livestock, they'll have to introduce maybe men in the value chain. So men will go, are the ones who are able to walk very far distance. They go and buy goats, then they bring to the women. Then the women will hold the goats, feed them, then sell them. Another chain, how they create another business, actually you need a transporter. People can be able to pick these animals from the point of delivery to maybe the slaughterhouse or a livestock market. So it resulted to creation of other businesses by them actually investing in these women. And you can see it actually has that ripple effect. It's not only benefiting the women themselves, but it is actually also opening up opportunities to also help men who are supporting this business along the chain. Other businesses they started were actually like tree gardenings, kitchen gardens, where they planted some few trees and then they sell as seedlings. They also planted some vegetables, which they also sold out to other people. Okay. An important statement, as you'll notice below there on the right, is in Gabra, women are vulnerable. They are actually perceived as kids in front of their society. Hence, when they formed the group, their voices were able to be heard. and their dependency on their husbands went low. So it relates to this women empowerment, also reducing that gender gap is also addressed by you investing in this. Community survey also showed us actually by implementation by you. Remember we mentioned that the community disease reporters went to the community, they trained them. Did it have an impact? We did a survey, and the survey showed us actually the awareness among us, the people who participated in the project was actually very high in terms of their health-seeking behavior. This is among the human health-seeking behavior, okay? They were able to go to the hospital because the first thing that comes to the top of their mind is that if I'm sick, I'll go to the hospital. But we also came to learn that some other barriers to entry, barriers of implementing this is the distance. It says to the doorstep, through the mobile One Health clinic, then they won't go to the hospital, the health facility because of the distance. Two, because of lack of money, they don't have it. Therefore, provision of these health services, which is customized to the setting, helps in improving that health-seeking behavior within a community. Notice that statement. Before, they said, we lived by virtue of God, and a person will be sick for a week. But now, after modern medicine intervention, the time of recovery has reduced. They have gotten to appreciate the importance of transitioning from traditional medicine to modern medicine, and they are able to actually inform us that it actually acts very fast, the modern medicine. Another, I'll just provide some few examples, 2 examples of the impacts, is increased awareness of zoonotic diseases amongst those people who are involved in the project. Okay, but we also came to learn they also practice other risky behaviors that like improper disposal of animal byproducts, like within the Gabra or these pastoralists, camels especially, the placenta of the camel, they'll always not bury it. They always want to throw it on top of a tree. Why? Because they believe the placenta of a camel is actually sacred. Otherwise, the other placentas of the other animals, like the sheep and goats, they'll just throw it on the ground, which from your studies, I believe, you'll notice that that's a point of, that's a risk point. A dog can come pick up that placenta, then that results to that cycle of hydatidosis if it is within the area. Okay. Yeah, so that's all about the One Health project implementation in Northern Kenya. Then our 7th example, which is our 3rd last, is the Mara Training Center. So the Mara Training Center, I think you've heard of the Mara in Kenya, whereby tourists normally come to Kenya to view either elephants or they view the migration of the wild beasts. That's normally, it was named the 7th wonder of the world. So what do? Remember, in this ecosystem, we both have the wildlife, then we have the livestock, then we have the humans. So what the center has done, it has trained the community members who are also pastoral communities, the Maasai, to coexist between the wildlife, livestock, and humans. What did they do? One is by training these pastoral communities on the importance of setting aside some sections of land, so paddocking system, all right? Then when wildlife are migrating, wherever the routes, they have actually mapped all the routes how wildlife migrate. So if let's say they know wildlife are going to migrate next month, then they will block out those particular grazing area, because they know if livestock go to graze those areas, then they'll come down with MCF, malignant catarrh fever. So that approach of disease management, but still coexisting with wildlife, is one of their center stones. Number 3, what they have done also is by doing that paddocking, they have resulted to reducing the number of livestock that are kept within a given area, so that you don't have overgrazing of livestock within the land. So they are therefore able to give land enough time to regenerate itself over time. And then number 4, they have established a slaughterhouse for the community, whereby the community can be able to deliver their livestock there. It is slaughtered, okay, and then they are given as dividends back to the community. So that holistic kind of land management has been implemented in this area. And as you can see, there are those added values, both to the environment, to enable it time to regenerate, to the livestock, and that coexistence between livestock and wildlife, to avoid the conflicts that you usually see when either, like you can see in the photo, these are the elephants which have invaded some fields of a maize plantation. Another example, second last, is veterinary practitioners. Is also a typical example of One Health application. Maybe in this session you are a vet, or we've already seen an example of how medical practitioners applied that in the separation of the conjoined twins. Vets also play a huge role, like during meat inspection, ensuring the meat that is delivered to the public is actually safe. Okay, disease control and prevention is also very key. And population control, as you can see, the top left photo is that's a dog being spayed. Yeah, it's actually being spayed. And by that, you're actually ensuring communities have manageable number of dogs that they can be able to feed and fend for. Because from our study, as an organization, World Animal Protection, what we've come to learn, why do we have a lot of roaming dogs? It's because, one, people actually do not have that idea that actually I can neuter my dogs so that I can be able to keep dogs that I can be able to manage. So this is the education we are passing to them. Disease prevention, vaccination of the dogs, okay, is also very key, so as to prevent these outbreaks of rabies. And then second last is this example I want to share with you called Syndromic surveillance system, which was implemented in Western Kenya. Some few slides about it. One, in the Syndromic surveillance system, you're basically looking at records that have been kept by meat inspector or the veterinary within that particular facility, okay? Then what did they do? A system was developed by Kestrel to this form, which was, then these forms were given to the meat inspectors who are able, they are doing their work. So if they're, let's say they're inspecting meat, they see a lump, then they'll check that lump, confirm what is there, then they report it within the system, but also taking a photo. You can see it, a sample record on your right. They'll take the geocode, the date, etc., the animal, basically some demographics of about the species, the age of the animal, the region, etc., and the findings of the postmortem inspection. So what are some of the results? So some of the results from the syndromic surveillance system, as you can see, is that it tells us the species of animals which have been reported, okay, for this section. And this data was collected between March 2017 to January 2018. The next slide is what is important. By you actually investigating the number of condemnations that have been done, you can actually quantify how much money we are losing within a society. As you can notice here, 9 cows are actually lost, carcasses condemned, which amounts to almost 13,570,000 shillings, Kenya shillings. For sheep is around 10,662 shillings, okay? And then another case is this quantification of the condemned, now either it's like a liver, okay? This is amount of money lost, 758 shillings, while for a lung, you lose almost 450 shillings. So by using this kind of information, which is quantifiable in terms of money, you can be able to make a case of investment in, let's say, disease control through deworming in the area. As you can see, we have flukes, we have edidosis, we have, what else? Cirrhosis. So you can be able to use this information to compare even the policymakers, implementers within your county to invest in some of this disease prevention and control. Then lastly, the case example I wanted to share with you is the ZDU. The Zoonotic Disease Unit is the One Health office in Kenya. What they have done, one, they have developed a list of priority zoonotic diseases in the country. Maybe I'll pass this question back to you. Do you have a priority zoonotic diseases in India? And maybe if you do, you can be able to share with us which are some of the common zoonotic diseases in your country that you've come about. The other thing that the ZDU has done, they have developed this roadmap for prevention and control of rabies in Kenya by 2030. And this has been piloted in some few counties which have been highlighted in that map. Something else, they have developed some contingency plans of this for Rift Valley fever, but also for anthrax has been developed, and brucellosis has also been developed, and others like the avian influenza is also being developed. The importance of having such maps is that they do tell you the highest risk where you'll have maybe, let's say, an outbreak of Rift Valley fever. Like the photo on the right shows you the red zones where there's red. That's where you have the highest risks. So even in deployment of resources, it helps you on how to budget resources in some of these counties. You'll know in the high-risk counties, I need to channel more resources, okay? So that's the importance of having such contingency plans. So that's the end of it all for in terms of cases. So I ran you through the last slides, which I would like to ask you, maybe in the chat, will you share with us any example of One Health in practice that you've come across? It could be a personal example, maybe a project you've already done or you've come across that interests you. It could be something that your government or your local leader is actually doing that you believe this is something, this is the application of One Health. Maybe you can share with us in the chat as One Health in Rabies Control Program in India. Thank you for that. And I can see also Shivam Raj had said District Animal Husbandry Department as I think a key stakeholder in One Health. That's good. Any other example that you can share? Yeah, serological tests are being done on mass level. Yeah, that's good. Thanks for sharing that. So these serological tests, I think they can help us in screening some of the common diseases affecting either people or animals within a particular area. So thank you. So we'll proceed. So what are the benefits? We've seen the One Health in practice, but is there really benefits of applying One Health? Yes, they're there. These are just the few I can give, but I know you can think of more. Now we are observing people from different disciplines. They're actually now communicating to one another. We are seeing sociologists talking to veterinarians, to medical practitioners. We've seen now projects when they are implementing their work, they're involving anthropologists so that they can be able to learn about the attitudes and practices of people in the community, which can inform their interventions. Different people are appreciating their roles they play, like animal health, human health, and environmental health. But here, I want to bring on board the non-traditional players in One Health. A typical example is architecturists. When they build a building, for instance, they know I need to position the building on this particular section so that I can have enough light to prevent rickets within children, that can be able to provide a balcony where children can go out and bask and have that vitamin D from the sun. So you might want to think also around that non-traditional applications of One Health within your society. Urban planning is also a good example. Engineers, when they're developing the roads, when they're developing maybe environmentally sewage systems, because when you have a very strong sewage system, which is sufficient, it prevents those outbreaks of even waterborne diseases. So that's how you want to think around also One Health, that practical application within their society. Then it's also bringing that social science perspective to health, in that it's no longer about just collaborating, but it's actually looking at what is the outcomes of our collaboration. Is it that we want to reduce the number of diseases within a society? Is it that we want to increase human health, well-being? Is it that we want to make our environment better and more sustainable in future? So those are some of the things you also want to look at. Then challenges, there are many challenges that are also facing One Health, okay? In terms of funding, there's no sufficient funding, I know, in some locales, okay? There's still that silo mentality among either students or among practitioners around One Health, okay? Yeah, there's still those existing challenges. And the solutions, how can you address these challenges? There are solutions. One is about integrating really One Health in our day-to-day routine, okay? Don't just talk One Health when you are going to collaborate with someone. Talk it in every day, even when you are eating with your family along the table, just mentioning to them, oh, did you cook the food well? Okay, the benefits of cooking food well, zoonotic disease that you can get from livestock, milk, etc. Yeah, so having that hands-on sharing of information with your family, colleagues, loved ones will really help. Training. Institutions should integrate these aspects of One Health. I'm very happy that the COHEART, I know you're collaborating with the I don't remember the exact name, but I know it's COHEART, which is an institution of applying One Health in India. That's amazing. Okay. County governments need to embrace also One Health as a prevention and control mechanism so that they can be able to provide budgetary requirements in supporting One Health interventions. Structures, here we mean that you may want to develop a policy within your government so that you can be able to implement One Health. Because if you don't have legislative instruments or frameworks within a country, then it becomes very difficult to compel the government to be able to support One Health directly. Because at the moment, you'll find that projects are fully dependent on funding. So the question you need to ask yourself, what if the funding dries up? It simply means that we can't proceed in implementing One Health. But if we have our countries incorporating it within our budgetary allocations, then it becomes sustainable in future. Then thank you so much. We are all in this together, and it's actually up to us to implement and put into practice our One Health. So thank you, and back to you. We'll take some questions.
Thank you so much, Dr. Kelvin. It was a lovely presentation, and you explained it quite nicely. So, yeah, if anybody has any questions, please feel free to type it in the chat box, or you can ask directly to him.
Thank you, Dr. Momanyi. It was very interesting to hear you. I think we have not met each other, but we have definitely talked several times in Facebook and email. Right. And Dr. Momanyi, I just like to know what are the running projects which you have currently as far as One Health, the type of projects are concerned.
Thank you, Prajit, Dr. Prajit. Pleasure to meet you. I know you haven't met physically. Really, really very happy to meet you here. So some of the projects ongoing, I know, around One Health in Kenya. One of them is being implemented by ILRI, Livestock Research Institute. They currently opened a new hub called the AMR Hub. I'll share a link in the chat. So that is one of the new projects now being implemented in Kenya. Another one is around the Kenya Livestock and Wildlife Surveillance System, which is being co-implemented by the WSU, Washington State University. So that's another good project. So AMR Hub at ILRI, I've put it in the chat. That could be a good one. And others I know which are still ongoing is the Rift Valley fever surveillance, the implementation of the rabies strategic plan in Kenya, and all this contacts can be gotten from the ZDU or the One Health office in Kenya. So at the top of the mind, those are the ones I know that are ongoing, but I know there are others. Like another one is AfroHoon. AfroHoon is the Africa Network for One Health Universities. So initially it used to be called HOSEA, the One Health Central and Eastern Africa, but now they have broadened to cover the entire of Africa. So this could be also another interesting area to look into. Thank you.
Yeah, thank you. Thank you. It was nice. I also heard about OHDI. There's One Health Development Initiative. With regard to, I think there's that's on NGO which is working on in Nigeria.
Yes. Yeah. Yes. I know about it. It's being run by Kiki.
Yeah, exactly. Yeah.
Right.
Dr. Kiki also spoke with some of our students and audience in the month of World Zoonosis Day. Yeah.
Pleasure.
Thank you.
Thank you too.
Anybody else would please feel free to ask the question. Dr. Kelvin is.
And as you're preparing to ask a question, I'm very happy that the students have this high competency of One Health, and they are able actually to share examples of practical examples of One Health application in India. This is very, very good.
Excuse me, Dr. Kelvin. I think we have a question in the chat box.
Okay.
Pastoralist communities, who are they? Asked by Ronak Singh.
Role no. So the pastoral communities, these were the Gabra community. So I've put it in the chat. So these are the Gabra community. So essentially, pastoralists are those communities who move around with their livestock. So they keep a lot of livestock in numbers like one person can have up to 100 cattle or even 500 sometimes. And then they might have 50 camels or 100 camels, and they tend to move from one point to another in search of pasture and water. So northern Kenya, I'm sorry I didn't give that background, is a very dry area, okay? It is where we have it's like a desert in Kenya. And therefore, water scarcity is a huge problem for them, and pasture and feed for their livestock. And that's the reason why they have to move. Yes, as you mentioned there, they are nomadic pastoralists. Correct. And being nomadic person, then you'll identify that approach of mobile One Health clinics is amazing because it delivers this integrated health services, both animal health and human health at the same time. So what the project did actually is they fuel a vehicle. Within the vehicle, you have a nurse, you have a medical practitioner, you have an animal health practitioner or an animal health technician, then you have somebody like an environmentalist. Then they go to one spot or one community area. In that community, so the animal health practitioner, they'll go and attend to livestock or camels by either the treatment, vaccination, and providing intervention. Then the human team will go and intervene with the humans, like taking measurements, heights for children, the MWAC measurements, which tells them about level of nutrition in children. But they also provide vaccination to humans, as well as if they find the women are highly malnourished, then they usually give them porridge. And then the other thing they used to give is water treatment chemicals so that they can be able to make their water safe for drinking. So that's how the integrated approach.